forward.
Hello, everyone. Thanks so much for coming back to join us for our interactive session. My name is Martha Jane Vincent. Please feel free to call me MJ. That's my initials. I'm with the Government Transformation Office with the state of Arizona. And just to introduce myself and let you all know a little bit about what our office does, we are a group of coaches and data analysts who work with the state agencies on continuous improvement. So really helping all state agencies find and identify problems and work through problem-solving methodology to close those gaps. We work closely with our agencies on their strategic planning processes and all of their sort of breakthrough, bigger agency problems that they're trying to solve. So what we're here today to do with you is take the topic that you've just had that great panel discussion on and do a little problem-solving work, a little solutioning. So we're going to go through a process. We're going to do an overview of the problem and how we're going to ask you to contribute today. We will do some root cause analysis. We'll do some solution ideation and then talk about taking action. I'm also joined by an additional member of my team, Michelle, and she's going to be sort of working with the visual aspect of our board that you see here in front of you, and that'll become apparent as we move through the session. The way that she is going to do that is by capturing your participation in the chat. So I want to take a minute to introduce our guests and of course, Nancy, our room moderator. We've got several experts in the field who are here to contribute, and that's awesome. Nancy, would you like to do a little introduction of those folks?
Yes, I do. Are we not going to be able to have video while we're doing this?
Do you mean, is it being recorded? It is being recorded.
Okay. All right. So the subject matter experts that we have today are Brooke Fulton, and she's out of the Flagstaff area, and she is the program manager at the Northern Arizona Care and Services After Assault. And she's an outreach program. She does outreach out of a program at the North Country Healthcare, and that provides medical forensic exams to victims of sexual assault and domestic violence strangulation. We also have Danielle Demelo, and Danielle is out of our Tucson VA. She's an licensed clinical social worker in the behavioral health interdisciplinary program. She is a program manager of one of their intensive behavioral health services, and she's the acting MST coordinator at the, okay, I already said where she was from. And Doreen Nichols, who is one of the presenters for the last event from the Survivor Engagement and Systems Change Specialist at Arizona Coalition to End Sexual and Domestic Violence. We have Jillian Holt, who is out of she's out of a vet center, readjustment MST, and MFT, which is a marriage and family therapist counselor. And Ms. Holt specializes in working with service members and veterans that have experienced trauma, both combat and MST. Ms. Holt is also married to a combat veteran and comes from a military family. In addition, we have Dr. Dylan Richard, and he also presented in the last session, and he's currently a graduate in the psychologist at the Phoenix VA, working in general mental health as part of their BHIP, which is the behavioral health team. And he has just been awarded the MST coordinator position at that VA. We have Stacy Salvo, and she is a licensed professional counselor, readjustment counselor from the Vet Center in Lake Havasu. And hopefully Reverend San Hong Yu will be joining us, and he is the founder of the Faithful City and Arizona Trauma Informed Faith Center, and he founded Arizona Trauma Informed Faith Community. And the next person we have is Joanne Schaefer, and she is out of the Northern Arizona VA, and she is the MST coordinator for this VA up here. And I just want to welcome everybody to this session. I do want to just say in the kind of the word of the day and yesterday is seamless coordination. So we're going to have a problem solving session today, which will involve that. Just put your information into the chat and it will be picked up, and then we will be addressing your input and any questions that you have. Thank you very much.
Thanks so much, Nancy. It's awesome that you all are able to join the session today. We're really excited to get started looking at this problem and doing some ideation. Everything that happens today is going to be directly taken back and used to create programs and procedures, processes, and opportunities that will work to solve the problems that we're identifying through the conference. So we're excited about that. If you contributed something that's, lots of people contributed during the first part of the session, and those great ideas and things may need to get captured in this. So I would encourage you to go find your comment and copy and paste it back so that we're collecting it as we ask questions and talk today. And for my experts, I definitely want to have a conversation for sure, but I also want to make sure that this great participation is getting captured in this really visual way. So please make sure that you are typing your great stuff into the chat as it's appropriate so that we can capture it here on our board. So you will see that we're going to jump right into doing some what we call root cause analysis. So our problem is, why isn't there coordination across sexual and domestic violence service providers? So we addressed some of that in the first session. And now we're going to kind of categorize these reasons. So we want to capture all the reasons that we think, why isn't there coordination? And I would invite you to, I'm just going to zoom in a little bit here on one of these notes. So you can start thinking about this a little bit in categories, right? So when we're trying to answer this question of why, are there certain methods in place that might be one of the reasons why? Are there policies or procedures? There's probably not any equipment, right? That's usually in a manufacturing setting, but there definitely might be people, right? We're never going to say, oh, it's XYZ person or agency's fault that this isn't happening, but rather there's things that they could do more to help us, right? Materials, is it about literature? Is it about social media? Is it about those sorts of tangible things? What are we measuring? One of the reasons why might be because no one's measuring it, right? What gets measured gets done is what they say. And is there environmental? And as we know with this topic, absolutely, there's a ton of environmental sort of reasons. So as you're typing reasons in the chat, go ahead and think about those categories. And we want to just capture, and Michelle is going to start putting those in. As you see, I'll recenter this. She's starting to put those reasons in for us that you guys are typing in the chat. So far we've got lack of time and staff. Providers across sectors aren't aware of other resources. State, federal, community resources, absolutely. Systems should provide a warm referral to an organization if the client isn't eligible for services with their organization, absolutely. A warm handoff. What do we mean when we talk about a warm handoff? That is more than just here victim, here person, here's the phone number or the email address of this other organization, or here's the list of their support services. A warm handoff is when we actually make that introduction. We get on a call together with a provider from that organization and our member or our client, and we make that warm handoff, right? No formalized partnership between government and community resources. No contracts with government and local resources. Yep, community organization and silos. Oh, absolutely. Disconnection between civilian and military services. And you guys talked about that quite a bit in the first session, which I found really interesting. Limited number of SANE nurses and staff. I'm guessing that SANE is an acronym. Although in these environments, you never know, right? But if whoever typed that could type out what SANE is, or if you are a person who's a guest, you could unmute yourself and tell us what SANE is. In acute care, there isn't enough of the population to serve in order to make a specialized program that targets this need. Okay, that's a really good point, right? It's everybody has their own special little issues, and there isn't those groupings. Forced competition among agencies with limited grant funding, absolutely. Lack of safe space and relationship with the issue. So we might be talking about peer support there, perhaps, if that's correct. If that person could type that in the chat. Okay, we've got sexual assault nurse exam. Awesome. I'm just gonna pop that in here. And spell assault right. Awesome. Overlapping services without a centralized hub, absolutely. Much difficulty getting someone on the phone who actually has the right answer. And this could be about the lack of coordination, right? Eligibility guidelines for MST services are complicated for survivors and community providers. You haven't made the time to prioritize collaboration and coordination. This is great, you guys. Just gonna start pulling some of these headings over, because the next thing that we will do is start. Okay, looks like that's a duplicate of that. Oh, you guys are trying to help me. Appreciate that. We're going to start doing what we call affinitization, and that's just a fancy word for kind of putting things in buckets. But please do keep putting your reasons up there. So why isn't there coordination across sexual and domestic service providers? And then think about what you answered. Think about your answer and then ask why again. Like sometimes it can be really helpful to get us to the real root cause. So for example, much difficulty getting someone on the phone who actually has the right answer. Why? Why is that so hard? What do you think the reason is that it's so hard to get someone on the phone? Right? So we start getting, you can think about a weed that's growing in your garden. If you come by and just pull the weed from the surface, the root is still there and that weed's going to come back up. Poor training across the board. Stacy, is that the answer to that question? It looks like it is, but could also just be another root cause, right? All right, so I'm going to start taking a look at these and thinking about what our headings are. Okay, we've got that captured here. I'm going to make another one. The no surprise funding issues. Services that primarily meet the needs of women are just recently being prioritized into veteran and military organizations. Mhm. I feel like this is more of a training or process one. So as we're looking at this and getting ready to move on to our next iteration, I want you to think about the stickies that we have here. Eligibility guidelines. This might be treatment and training focused. As you think about the items that we have here and recognizing all of these things are specifically going to get passed forward and looked at and used when they're building out solutions and programs. For the purposes of our exercise today, we're going to be taking the orange stickies and pulling them down to the next board to do some other activities. So when we're doing that, Michelle, if I could ask that you copy those and put them down there. And if there is additional ones that we think, okay, maybe we need another bucket. These things are really this reason, right? Please do let us know that. But also recognize that when we take these down, we are still talking about all of this great feedback and great ideas that you've come up with, right? So when we talk about partnership and silos, we're talking about all of this stuff as we take these down. So think about, are we missing an orange bucket for a reason why there isn't coordination across sexual and domestic service providers? Right now, we have reasons that are financial, funding focused, treatment or training focused, a partnership or silo focused. So are there different ones? Not enough providers have military. Yeah, we got that one. Okay. All right, awesome. So we are going to go down here. I'm sure Michelle will bring our other one down there. So what we want to think about next is, what are some solutions that could help address this lack of coordination? And we have our buckets up here, so we remember sort of what our topics were. So now it's time for, what are all your great ideas? And just so you know, the next step is to talk about more specific actions around who would do this. When do we think they should do this? Who should be involved? So that more details will come next. But right now we want to just get out every possible solution that we think would solve some of these challenges that we're seeing, some of these root causes. So I would invite you to start throwing out your solutions. Lack of time and staff could be a funding issue. Absolutely. Community input from Arizona survivors on what the needs and gaps are. Definitely. One of the big pieces of work that we promote is what we call voice of the customer. What does your customer want? And what do they say is the priority? Increased federal funding, absolutely. Statewide working groups, public-private partnerships, Good stuff. Developing a consortium of community, local, state, and federal agency representatives that meets regularly. Prioritizing hiring providers with a military background, increased MST training and certifications. Increasing awareness of resources and networking amongst professionals. Joint veterans agencies and the DVSB community statewide conference to focus on collaboration of service gaps. Yep, I saw that in the chat from earlier. Thanks for bringing that down. A playbook that can help providers who don't deal directly with issues presented so they can still point veterans in the right direction. That's a great idea. Identify grant funding available to start programs through already available resources. Definitely. Incentives for survivors to participate in voice of the customer work. We can't expect free emotional labor to provide us this information. Sure. Available training. VA training to providers in the community that are uneducated to VA processes. Sure, that's a really good idea. The opposite, right? Educate the civilian providers about their veteran needs. Increasing awareness of intersectionality with trainings and discussions for genuine development of collaboration. Awesome. Statewide coordinator or peer navigator to help guide survivors. Time and space for these kind of coordination or partnership discussions, absolutely. Formal contracts between government and community agencies. For Southern Arizona, this would be formal partnerships that our VA develops with Emerge and AHCCCS, okay.
So there's, I don't know if this got picked up, but there's providing the time or space for these sorts of discussions, right?
Yep,
I
it's
think we
here.
need more of these planning sessions.
Yep, we've got it here. Peer specialist at the VA level assigned to sexual trauma and domestic violence. There's a question for the VA panel experts. Is the MST coordinator a full-time or FTE position, or is it a secondary billet? If any of my vet people for Southern Arizona, it's full-time. Engage academic leadership to develop concentrations on MST trauma programs and provide stipends for students. Increased funding for outreach and prevention. A lot of funding is limited solely to response. Good. Coordinating care for active duty members that are experiencing MST and getting them treatment right away. Also more training, counseling to help prevent MST. Yeah. Re-victimization. Effective intervention programs for offenders, people who do harm. It's a whole other side of the coin, isn't it? Coordinating with NG Reserve and using community providers when they are not eligible for traditional services due to status. So being able to offer resources instead of just a no. That's great. To add to offender treatment, effective offender treatment training, very few providers at the VA are comfortable with this treatment. There are no VA approved treatments for sexual offending behaviors. To Doreen's earlier point, increased work to decrease stigma of coming forward and education for investigators about dynamics of sexual assault. I'm not sure about military rates, but for civilians, only 25 out of 1,000 rapists will be incarcerated. Wow, that's a pretty scary statistic. A way to have more education upon exiting the service. Absolutely. People are reticent to seek out help, but if it's brought to them, they might accept it. All right, these are great ideas that we're coming up with. I'm going to go down and show you, I'm going to probably wind up coming back to this board. I'm going to show you the next board. And I want to think about what specific actions can be taken and by who. So as we are thinking about all of these great ideas that you've come up with here, think about, who might need to be involved, what specific action needs to be taken to create a public-private partnership, right? What are your ideas around that? What specific actions might need to be taken to implement more effective intervention programs, right? Who would need to be involved in that? So you can take your idea and think about those questions. And we'll start thinking about what specific actions need to be taken and by whom. And if you want me to pull your idea from up here, you can just put that in the chat, reference a couple words and we'll be able to find it. We'll be able to make those connections. Brooke, I'll make sure yours gets included if Michelle didn't get it. I think she probably did, but up on this one. Coordinate with the Board of Regents to create a military affiliated trauma survivor curriculum certification. Ooh, that's a good idea. Coordinate with local bases and forts to have education for people entering and exiting the military, increase awareness of services for providers and service members and veterans. Awesome. And again, just remembering that they are going to be taking this information to work directly on programs and processes that will address this problem. So if you think there's an action that they can take, let's capture it. Let's get it in there for them. Oh, looks like I'm having a little bandwidth issue. Hopefully y'all can still hear me. Let's see what else we have come up with. That one. State agency to create an FTE to help coordinate this effort on a statewide level. You may not know, but if you know, what state agency would be appropriate? Veterans? Probably, right? That would make sense. VA MST coordinator to create a partnership with local military and streamline processes. In an SOP for transition referrals, great. For the playbook, oh good. We could require individuals from community care, VA, vet center to come together and hash out the important details. Then having someone who can edit or compile the information in a sort of decision tree or laminated handout that can be posted on providers' desks. That's an awesome idea. Teams meetup or group symposium for MST providers to meet, talk, train annually for state of Arizona. Absolutely, kind of a community of practice even. So Arizona Coalition to End Sexual and Domestic Violence is the designated agency from the Federal Department of Health and Human Services. So get them involved. We could also help with some collaborative grant proposals. Awesome. Helping to normalize for vets that accessing community resources is appropriate since we don't always have what the vet's looking for. Absolutely. That's duplicated. Action Vet Centers and VMAC can meet with local military bases to provide an in-service based personnel about MST. Awesome. MST Roundtable hosted by federal legislator about the gaps and barriers to care for military sexual trauma survivors in Arizona, or our experiences with the Phoenix VA system, MST teams, or VBA processes. Awesome. We really like the idea of involving legislators. That's fantastic. Let's see if it will let me turn my camera back on. Create a collaborative between trauma providers to share barriers to treatment. Awesome. Yep, legislators can put pressure on the AZ VA facilities to create more FTEs devoted to this work. So I'm just going to, since we have plenty of time, I'm going to go back up here. I know that they're little, so they're a little hard to read, so I'll try to zoom in a bit and see if this is going to spark anyone's memory or ideas about what specific actions could we take that would impact or make some of these solutions come to reality. Oh, I love that, Jessica. Public searchable database on trauma-informed military cultural trained providers. Yeah, that's really a good idea. Just kind of scrolling around the screen to let people remind ourselves of what ideas we came up with. We may have captured something for this, but if this person who wrote about formal contracts has any additional ideas for specific action that would need to be taken around that, that would be really helpful for them. head back down here and see how we're doing. Are we talking about one legislator? I think we probably are. If not, let's make sure we clarify that. Create collaborative, oh, why is that in my way? Create collaboratives between trauma providers to share barriers to treatment. As a member of the ASU School of Social Work and Community Advisory Board, I could bring up the need for this to be included in the MSW program curriculum. Absolutely, you could. That's a fantastic idea. And how do we create connections between that board and the potential great work that we're talking about doing with other coordination, right? Information and awareness campaign. Yep, that's very true. Information and awareness is awesome. And then you have a million customers that you can't serve, right? Symposiums after the fact, the session before that discussed potential symposiums, and many of them I had no idea about. So some sort of way to get those resources known. Bringing the STAR behavior health provider program to Arizona with a link to it. That's awesome. Thank you so much. Yes, some places have slowed on outreach because they don't want to offer services they can't provide. That's a real problem. Community providers that are military friendly or come from military background advertise that they are veterans, so veterans know. Sure. Vet centers, most of our providers are veterans or family members of veterans. Yeah. Mm-hmm. The position's vacant. Yep. Can be very difficult to find the right person or someone who's willing to do this work. Absolutely. Everyone, this is such impactful and valuable feedback. We so much appreciate that. I want to make sure that we leave, please keep putting things in the chat. We're going to keep capturing them on the board for sure. I want to make sure I leave an opportunity for people to ask questions, for further discussion to happen that might spark more ideas. All of the guests that were introduced at the beginning are able to unmute themselves and talk. So if people want to ask questions of them, or if we want to have a little bit more discussion, I would welcome that because we do have time. So I want to offer that as an option. Let's see. Increase our trauma-informed approach, even when not in SA service settings. How would we approach daily life if we assumed that statistically there is almost always a survivor in the room? Trauma-informed care is incredibly important. Advocating for sufficient resources to provide the needed services. Trauma-informed approaches should be prioritized in all school curricula for all the disciplines: nursing, physician, psychology, social work. Absolutely, and we do see movement towards that, right? But it's bringing awareness to that need is incredibly important. So many wonderful ideas. For statewide trauma-informed care movement, AHCCCS consortium. Awesome. I love that. All these resources getting shared. Arizona Trauma Institute. So a resource for Headstrong. Yep. National agencies. Longer term solution, Danielle would like to see a trauma team for VAs that does not just include PTSD, but for any veteran experiencing DV, SA, IPV, or any form of trauma. Currently, MST is separated from PTSD program. Well, that's interesting. And IPV program is not even within our service of mental health. Wow. Yeah, that kind of coordination, even within the VA, right, is so important to point out that need. When you get right down to it, trauma is trauma. Let's see. Oh, trauma-informed faith community, that's awesome. More 501c3s submitting proposal for VDF grant to build capacity, start veteran programs. Definitely. This person works on the Be Connected support line and can usually tell within a few minutes if the veterans experience MST or IPV, and they're all afraid to ask for help because of the military culture. They're supposed to be the helpers and leaders, not the people in need. So important to point out that point of view. Those are great. So in Phoenix, the MST clinic is within the PTSD clinic, which works out really well. And if that could be a standard statewide, Stacy's group has a mobile vet center for big stuff, but it would be awesome to have a trauma team that rotates out so that no one gets burned out. They could be more boots on the ground. That's awesome. Just gonna flip those so that we know those are linked. Resource for Boulder Crest. Well, I think everyone would agree that this has been incredibly valuable. We still have plenty of time in the session, but it sort of feels like we're coming to a natural close here. But please feel free to continue the conversation. We'll be here to continue capturing that, or if people have any questions that they'd like to type in the chat that any of our experts might be able to address, I would welcome that to happen. The follow-up to this. So yes, so we are going to take all of this data. It gets turned into a spreadsheet, so it can be easily sorted and parsed and things like that. And we will share that with the organizations, and they are going to then continue doing solutioning and problem solving. I think the direct quote was create programs and things to address these issues is the next step. That's interesting. Combat related PTSD, and it excludes MST. Interesting. Yep, the actual collaboration work is definitely what's needed next, for sure. It looks like there's plenty of interested and active parties who are ready for that. Awesome, thanks for including that link to the survey, Jessica. That's an opportunity to continue the conversation there. Continue being informed about what's happening for follow-up. Vet centers see all MST veterans active duty guard regardless of their time in the service or discharge type. Oh, that's good news. Danielle reports that the MST coordinator position is starting mid-May, if it all happens. And you'd like her to be involved in this, okay? And have a peer starting in BHIP, first peer position. Awesome. Okay, it looks like we're about at a point where we can start to wrap things up unless there are additional questions or comments. I know that there is another general session after this. So I'll give people that opportunity to go fill up their water and grab a snack before that happens. Any additional comments, questions, or anything that anyone would like to share?
Martha Jane, I just wanted to say that there's a lot of momentum with the collaboration, coordination, identifying resources, etc. So after you do your magic with all this information, I really wanted for us to identify some point people to start making a list of the people that are involved or interested in doing coordination and collaboration moving forward. So this information doesn't just sit on a shelf or in an email folder. that we can
Yeah.
actually start doing something with it and start coordinating statewide.
Absolutely. I think that's really important. I think that there is a way, Stacy, that people can get involved in that coordinating. So I think that that's about, if you feel like your name has not been captured here as a participant, please put it in the chat with your contact information and we'll put it straight on the board. But obviously, Doreen, anybody who was listed as a guest on that first slide, they're going to be informed and asked to participate. And we'll just make that, make that clear that that was an ask, right? And so if there's other folks, yeah, Dylan, for sure, you're on the list. So that, all of this is going to be captured and we will pass all of that along that folks are ready, right?
Wonderful, wonderful.
Definitely. Awesome.
Great. This is wonderful.
Just making sure that we capture that. Everybody wants to be involved. Awesome. Thanks to everyone so much. Have a great rest of your day and definitely hit that SurveyMonkey link so that you can stay informed about follow-ups. Thanks, everyone.